So having fallen so low, according to the median to regression principle in the statistics, I can only go up by chance. So lipids are just a part of the many unknown, known, and also we have to admit that there are also very, there may be unknown mechanisms that are not routinely measured in the contribution to cardiovascular risk. This is something that we humbly have to acknowledge. There are many scores in the general population, and some of them have been also used in people with HIV, but all of them are inaccurate and at some point predictable. In reprieve population, as we have seen from the excellent presentation Dr. Malvestuto has shown, we have seen that the reliance on the measurement of the cardiovascular risk scores for women is quite different from men, yet the risk is apparently similar. So we are faced to a reality, a situation in which the expectations of measurement are completely biased. Also, we have seen, according to the reprieve, that depending on the risk strata, the number needed to treat may be different. This may be quite more readily seen here, and you can see that with this, the benefits of statins are not the same for different risk strata, and more people need to be treated than will benefit. And this is something we have to accept and put in the shoes of anyone having to take statins and thinking if it will be useless. There are different guidelines. That's good, but there are different recommendations. So which ones to follow? You can see that the preferred cardiovascular risk tool is different between United Kingdom, between the United States, and between Europe. And there are also some other differences. Which is right? We do not know. What we know is that trying to adapt any risk score to any other, and this is the unique publication I have seen with the American Cardiology and Heart Association with the European risk score, the risk strata are very different and are difficult to measure. And in fact, the reprieve has clearly shown, this is not published yet, but will be probably, that assuming the risk with the score, the score equation, underpredicts by 20% the risk that the American score may be predicting. So again, we are relying on very much uncertainty. The risk for cardiovascular disease is not the same everywhere. We have been shown this study from these authors, but a different publication, and we have seen that the risk of cardiovascular disease in some parts of the world may be low enough not to apply the global results of the reprieve study. We also know, unfortunately, it has been published recently in Lancet HIV, that there are no major effects of pivastatin on non-cardiovascular events. And that puts on hold the conception that the pleiotropic effects of statins may be also useful for non-cardiovascular events. Statins, we have heard that they are safe, but there are a lot of studies showing that they may have clinical relevant adverse effects, and some of them are increased insulin resistance and even the development of diabetes. This is not minor. There may be clinically relevant drug-drug interactions. That's something important to consider. And statins also have a cost. This cost may be low, but it is quite diverse across statins, with a difference of over 100 times. And for the individual person, it may be hard to assume, particularly in the long term. But for the public health system, it may be even harder, particularly in some countries. The large-scale implementation of statins, and not only for women, but for any person with HIV, may be difficult for other reasons. So we need to think that there is a world outside the HIV field. There is a public health system, there are primary care doctors, and they have to be aware of these indications and the differences the general population may have with people with HIV. This is not ready to be changed, at least immediately. And maybe healthcare practitioners will be facing other issues such as adherence or trying to see whether the statins are efficacious or not. Adherence is a big problem. This is Australia. More than 100,000 people followed. You can see that even in the first year, there was an attrition of nearly 30%. And this attrition was increasing over time. So the reality is a big one. And at the end, is there any impact of cardiovascular screening? This is a New England Journal paper in 2022 in the general population in people with high cardiovascular risk, those aged 65 to 74. In these persons, ultimately, the screening for cardiovascular disease and the use of statins was useless according to the death. Oh. So there was no significant change. So for all of this, I request you're changing your vote, at least some of you, just for us to increase. Thank you.